light. Hopefully we'll still have more. I'm just going to stand here so that the video can record me, because we will also be sending out a video recording that you can share if you'd like. Welcome, my name is Rachel, and I'm the Director of Learning and Support Services with Alzheimer's Calgary, and we're so happy to have you here tonight. As you were waiting, we were playing our slideshow, and we were highlighting some of the programs and services that we have at Alzheimer's Calgary. Some of the things that are coming up is Canada's first dementia inclusive park, which is really exciting, and keep your ears tuned for more information on that. We also have a newly launched Still Me campaign. So you'll notice a lot of the imagery, you can see it right now, is really showcasing the fact that when someone has a diagnosis of dementia, it's still me in here. They're still themselves. It's just sometimes it makes it a little bit harder to communicate, or as care partners, we have to find new ways to communicate and find the person that's still in there. There's a beautiful website if you ever want to check out stillme.ca, and it's all about being part of the movement for action. By visiting the website, sharing our stories, and engaging, you are helping tackle the stereotypes around dementia. We also have some great handouts in the back for more. We also have a lot of programs and services at Alzheimer's Calgary. If you see anybody with a name tag that looks like this, you can go up to them and ask them about our services, and we also have some program information in the back. But we have our dementia support navigators who provide free support for care partners and folks living with dementia. And primarily they offer support in the areas of system navigation, communication strategies, and emotional support. We also have wonderful education sessions. If you check out our website at alzheimercalgary.ca, there's lots of different information sessions for care partners. We also have a day program, and I also want to highlight the fact that we are offering a newly diagnosed course. This is for people that are recently diagnosed and their care partners. It's a 3-week course. It's 2 hours per week. And the goal of the course is to really get people connected to each other and to prepare themselves for the journey of dementia so that they can not be so scared of it and feel more confident. If anyone is interested in learning more, you can just call the office and we'll connect you to more information. Finally, if we have any professionals in the room, we do offer a 1-day course called ABC Pro, which highlights how to build their skill set around with folks living with dementia. And a reminder that on Thanksgiving Sunday, the IG Wealth Management Walk and Run is taking place. This is a fun, family-friendly event, and our biggest fundraiser of the year. So we would love to see you there. Now I'm going to give you some housekeeping items, because perhaps I had your full attention for that. Many of you have evaluations. If you can fill them out at the end, that would be wonderful. It helps us make our programs better. If you didn't receive one, you will also get a copy of it emailed to you. And if you want to fill it out then, that would be great. The emergency exits are over there and over there. Oh, wait, no, over there. And right there, and right there. You can just run around Christina if you need to get to an emergency exit. She will help you out. And also, if anybody needs to use the restroom, they're just out in the foyer. A little bit about our format today. We're going to lead with the chat with Christina and Dr. Smith, and then we will open up the floor for questions. We usually have about half an hour for questions. We just ask that people try not to share personal information or ask for medications that's very specific. We really want you to keep the questions general so that as many people as possible can learn from the questions. We have a large group of participants today, which is great. So we really want to focus on keeping questions relevant to the presentation. And if we don't get to you, you can always reach out after the event. All right, and then we have a land acknowledgement before we get started. We really want to acknowledge and show our appreciation that this training is taking place on the traditional territories of the Indigenous signatories to Treaty 7. This includes the Blackfoot nations of Siksika, Piikani, and Kainai, and the Tsuut'ina First Nation and the Stoney Nakoda of Moreland, including Bearspaw, Chiniki, and Goodstoney First Nations. We also walk in the footsteps of the Métis Nation of Region 3. part of land acknowledgement is a call to action. As an organization, we've been working to increase our cultural humility. And while attending an Indigenous information session this week, I actually heard something interesting. They referred to a fact that a lot of Indigenous people view Mother Nature as our caregiver, our unconditional caregiver who takes care of us from birth all the way to death. And I thought that was really beautiful and poignant, especially considering our focus for tonight. So keep that in mind. And now I'd also like to thank our sponsors. They're at the back if anybody wants to say hello. They are Origins at Home, United Way Calgary area, the Alberta Retired Teachers Charitable Foundation, and the Freckleton Family Foundation. All right, so now I'm going to get to the interesting part, which is the speakers. I have to tell you a little bit about them first. So Dr. Smith, this lovely person over here. He's the professor of neurology, radiology, and community health sciences at the University of Calgary, and the holder of the endowed Kathy Taylor Chair in Vascular Dementia. He's the medical director of the and a member of the Calgary Stroke Program. He directs the clinical and research fellowship program in cognitive neurosciences. He's a member of the executive committee of the Canadian Consensus Conference on the Diagnosis and Treatment of Dementia. Say that 5 times fast. And his research team investigates how cerebral small vessel diseases cause cognitive impairment and dementia. And interviewing him today is the lovely Christina. Christina Frangou is an independent journalist based in Calgary, and she writes about health and social issues. Her work has appeared in Maclean's, the Globe and Mail, Chatelaine, and The Guardian, among others. Her work has also been recognized with the National Newspaper Award and 2 National Magazine Awards for feature writing. And she's the 2022 recipient of the Landsberg Award granted by the Canadian Women's Foundation and Canadian Journalism Foundation for bringing a greater profile to women's equality issues, which is awesome. So without further ado, I will hand it over to our speakers. I'm going to hand my microphone over to Dr. Smith.
Thank you, Rachel. And so I still have my lapel mic, and I'm not quite sure how this is going to go, so I'm going to talk very loud. If I am too loud, just wave at me from the back. Try and give me an indication if I'm too loud or too quiet, but I'm going to err on the side of being too loud. Does that work for everybody? Okay, great. It's good to see you. Thank you for coming.
Thank you.
It's really nice to be here. I feel this is a conversation that I am having in my family with all my friends about how as families we are working our way through this as we watch people we love start to age. And so I wanted to start with trying to understand what is memory changes with normal, the difference between memory changes with normal aging and warning signs of dementia.
That's a great question, and something I talk about with a lot of patients in the clinic. Like, it comes up all the time because to forget things is just part of the human condition. Everybody forgets things at any age, right? But there are some changes with age too. Remembering certain things becomes more difficult, like the names of people is often, that you don't see that frequently. Even with normal aging, that often becomes more challenging. The speed of thinking a bit slower with aging as well. Of course, aging is not all bad too. There are lots of good parts about aging cognitively, right? What we have learned and understood, our knowledge, our experience, and wisdom, these things are all things that increase with age, right? But certain things like learning lists of new things quickly, or the ability to think quickly despite lots of other things going on, like multitasking, these kind of things decrease with age. And we see that in studies that use cognitive tests to try to measure these things. The kind of forgetfulness that is a story that would concern me more as doctors and patients, or when the forgetting is interfering with kind of ability to do things that people used to be able to do. Things like interfering with filling out a shopping list, maybe more than just an occasional, like, oh, I forgot to get, the clean or something, but being unable to finish. So the kind of forgetfulness that's really interfering with people's activities. the kind of forgetfulness that leads to awkward or socially embarrassing situations is, I think, sometimes a little more concerning. You know, like repeating a joke or a story at a party where, and, you know, after 5 minutes after telling it the first time, and you know, you can see the look on people like what's kind of awkward. Those kind of lapses are going to be a little bit more concerning, and that might be a reason to talk to your doctor. Do other tests of memory, and then to try to help understand that distinction, like is avoided from normal aging to where when tests or evaluations are needed to rule out a brain condition, Alzheimer's disease or Alzheimer's.
I want to ask about a term I hear about.
Sorry, just before you continue, I've been told that it's still a little quiet. So Christina, I'm gonna give you my microphone, if that's okay?
Sure.
And Dr. Smith, if you could pretend that your microphone is in the ice cream cone and it's a hot summer day and it's melting really fast, and just like hold it really close.
Oh, yeah.
I think then people might be able to hear you better.
Uh,
But don't lick it.
Generally a good law. I wanted to ask about a term I come across in my research all the time. I hear talked about in medical circles, and I think it's confusing about where it fits into this world. Where does mild cognitive impairment fit into this discussion?
Yeah, that's a medical term that's used for a specific circumstance where there are changes in memory noticed either by the person or someone who knows them well, like a spouse, or maybe the doctors noticed it. And there's objective evidence that memory is not good on testing. Tests that a doctor might do in the office include one called the Montreal Cognitive Assessment, or one called the Full-Steam Mental Status Exam. They usually involve, you know, learning a short list of words, sometimes like counting or repeating things. And on these tests, we can get an assessment of people's objective ability to remember things. But in contrast to the syndrome called dementia, in mild cognitive impairment, the symptoms aren't so bad that it interferes with people's ability to live independently. So people may find it harder to do things like, you know, to check and double check the grocery list, you know, might need a little bit of help doing more complex financial activities like taxes, might need to leave reminders on their phone around the house, but are still functioning on their own. You know, they could live on their own for periods of months at a time without needing help. The other syndrome called dementia is the term we apply to changes that are interfering with people's function. With dementia, people need some help to function on their own over the days and weeks. In the milder stages, it might be needing some help with, you know, paying bills or doing the shopping. In more moderate to severe stages, it might need help, you know, getting dressed or reminders to bathe or shower, or help with those kind of functions or to eat. So mild cognitive impairment, then it's a name for a collection of symptoms. It's not a disease in itself, and as a doctor, you would do tests to find out, you know, why mild cognitive impairment might have occurred, right? And the fear is it could be something like Alzheimer's disease that will get worse over time. But not everybody with mild cognitive impairment gets worse. You know, this is where we're getting closer to the border zone between like what's normal for aging and what is due to a brain condition like Alzheimer's. On average, people with mild cognitive impairment, 10 to 20% might get worse and progress to dementia per year. But many people don't. And some people might meet criteria for mild cognitive impairment, and later they see better. So other things we think about are reversible things, like could it be due to medications interfering with thinking? Could it be related to poor sleep? Could it be related to like stresses in people's life, you know, related to or even being depressed or anxiety? So we think about all of these other kind of contributors and try to, you know, optimize them and see if the mild cognitive impairment.
So that to me suggests that as soon as you start to see things like this, you should talk to your doctor rather than putting it off. Right?
Yeah, I think it's good. There's there are barriers sometimes to talking to your doctor about it, right? I think one barrier is just kind of fear that maybe a problem that one is concerned about will be acknowledged, right? You know, there is a stigma around having cognitive disorders that doesn't exist around, you know, other conditions like heart condition. So people may feel more comfortable talking to the doctor about chest pains than about changes in cognition. You know, you know, these conditions are, you know, if it does turn out to be something like Alzheimer's, there's no easy solutions, right? There's no kind of cure for Alzheimer's. So we'll probably talk about progress on medication on Alzheimer's later, but there's still not an easy fix or a cure. So people say, well, why should I bring it up, right? It can't be fixed, but that neglects that there are things you can do to help even without a cure. You can, understanding what's going on, it helps people plan for the future better. And there is advice we can give about general brain health and keeping the brain healthy. And particularly when people are coming with the mild stages, it may not be Alzheimer's, but there's other things that can be addressed. So for example, psychological stresses or mental health problems can sometimes be managed or, you know, helped with psychological therapies or other medications, for example, for depression. Sleep could be improved, medications that aren't good for memory. Some people may not recognize that, like, you know, some of the medications used for water problems, for example, can interfere with memory or for diarrhea. So medication you might not think about, as well as avoiding sedatives. So there are things that can be done, right, to help, like, recognize, plan for the future, and sometimes help make memory problems better. There are good reasons for people to bring it up. I mean, another barrier to be frank too is that, you know, people's doctors vary in terms of their ability to feel comfortable as a doctor, right? Like doing an assessment. So I'm a specialist, so I do a lot of this. I'm very comfortable with it, but not every family doctor is as comfortable. So sometimes you need to be a little persistent even in asking that question so that the doctor will take it seriously and either do an assessment, or if they're unable to make a diagnosis or do an assessment, to make a referral to a doctor who is capable of making these kinds of assessments. So that's another area for sometimes.
I don't know what the situation is for people in this room, but I write a lot about people who can't get primary care physicians, and so just if someone in this room doesn't have a doctor with whom they have a regular relationship, and they're wondering about themselves or their loved ones, what do you do if you don't have a regular family doc? Do you go to urgent care and ask for these tests? How can people get these tests done without a regular doc?
Yeah, I think that's a challenge. I mean, first look into getting a family doctor, though it's easier said than done. Even in a city like Calgary, where you have a higher density of doctors, you know, it's not easy. So if you go to Alberta Health Services website, you know, they can you can find like a list of family doctors accepting patients. It's not easy though, because sometimes you have to call multiple people, and it's this up to date, and you call and say, well, we were, but we aren't taking the patients anymore. I think going to urgent care is something that's reasonable, particularly if we need help like soon, like there's kind of like a crisis. I think probably the Alzheimer's Society would agree that by calling, asking for more advice or help on how to get connected in the healthcare system to doctors is probably within their scope and how they can help people as well. So I think we're all of these ways that we can get help. You know, it's even more challenging sometimes in a rural setting, right? We understand that's a challenge. Since the pandemic, with the advent of doing more Zoom calls and more telehealth and telemedicine, that's one way to try to bring more expertise to rural communities. It's a little bit more challenging, I think, to do an assessment of cognition and memory by Zoom or analogous like video conferencing software than it is in person. I prefer to see someone in person, but there's with the pandemic, you know, we've developed better ways to do this, so remotely that have been validated. So that's an option too, to bring expertise to people in communities where there's so much expertise locally.
Now, your expertise is in vascular dementia, and I'm gonna get you to talk to us a little bit about that. What is the difference between, compare vascular dementia to other kinds of dementia?
Yeah, so the dementia, as I mentioned, is a term for the symptoms. It's severe symptoms in memory and other aspects of thinking that prevent people from taking care of themselves and living independently on their own, or requires people to have some help from others. So that's the name of the symptoms, and then there's the set of brain diseases that can cause these symptoms, of which Alzheimer's disease is the most common. Alzheimer's disease refers to a condition where if you could look at the brain under the microscope, which you can't do with living people, but if you could look at it under the microscope, you see plaques and tangles in the brain. And the plaques are made of a protein called beta amyloid, and that seems to be the thing that starts this process in Alzheimer's disease. So it's a specific brain disease, but there's other diseases that also cause dementia. So that's not always understood by everyone, because you read about Alzheimer's and dementia a lot together in the press, and you might think they're one and the same thing, but one thing is the symptoms, that's dementia, and the other is the cause, that's Alzheimer's disease. But there's other causes. The second most common cause is vascular dementia. Vascular pertains to problems with the blood vessels and the blood flow. So that includes people that have had a stroke. So strokes is a condition that's caused by either a blockage in the blood vessel, or the blood vessel is broken and blood has come out, it's bleeding in the brain. And that can cause symptoms like paralysis, difficulty speaking, but that can also cause memory and thinking problems as a consequence. Another cause of vascular dementia that's been recognized more so in the last 10 or 20 years on brain scans is that sometimes we have people who have memory problems. We think, oh, maybe it's Alzheimer's or something else. We do a brain scan and we see that they've had little strokes in the brain that haven't caused paralysis. In fact, they were never diagnosed with it before. We recognize it with the brain scan. So it shows up only after the genes. And other changes in the brain we see from blood-flow tubes, things called white matter lesions, or spots that appear in white matter of the brain. The white matter is the internal part of the wires from the brain cells used to communicate with each other. So sometimes you only recognize the vascular component after brain scans. And then we know a lot about what causes blood vessel conditions, and that include the main risk factors: having high blood pressure, also conditions like diabetes and smoking, or diet contributes to this. So there's a bunch of things we can look at with vascular dementia to try to make the blood vessel health better, and hopefully prevent more strokes from occurring and preserve.
So if someone has vascular dementia, there are some things that you can do to hopefully improve their situation. Do you ever see a reversal or improvement in their symptoms?
If the cause has been a stroke, there is a recovery period after stroke. So, the brain, compared to other organs in the body, the brain has more limited capacity to regenerate or heal itself, although it does have capacity to rewire itself. It's a phenomenon called plasticity. So when we have someone who's had a stroke, over the next kind of 6 to 12 months, the brain can recover and adapt. So after a stroke, there is potential for recovery, and for certain aspects of thinking and communicating, like for language problems after stroke, there are even programs that speech therapists can do to try to augment plasticity by helping train people, to speak better. So after stroke, there's a recovery period, although not everyone recovers fully. For the kind of vascular dementia that we see when we recognize it on a brain scan, often the amount of changes in memory thinking have been established at that point, and then the recovery may not be possible. But with attention to treating vascular risk factors and optimizing blood vessel health, we can often reduce the risk for further decline or stabilize it so that hopefully more decline doesn't occur.
And when we talk about reducing the risk for further decline, or reducing the risk, to start with, what are things we can do, all of us, that reduce our risk for dementia? Is it the same as would be for vascular dementia?
Yeah, there's a huge overlap between the risk factors for dementia in general and then the risk factors for vascular dementia. So it has very strong implications for promoting brain health and preventing dementia. There's about 11 or 12 things that have really strong scientific, top quality scientific evidence as being risk factors for dementia that may be modifiable. It includes things like physical activity, like being less physically active is a risk factor. Having high blood pressure is a risk factor for dementia. Having diabetes. And the other thing is that if you are diagnosed with diabetes or hypertension means high blood pressure. If you can get them under control, there's good evidence that reduces the risk substantially. So it's something to work on if you have that condition, or make sure that you have a big screen for that condition appropriately. Other aspects include nutrition. So eating a heart and brain healthy diet. The best evidence is probably for more Mediterranean style diets where you get more sources of protein from fish or from white meat like chicken, and kind of red meat in moderation. And eat good, ideally 4 or 5 servings of fruits and vegetables a day. So diet is an important factor as well. I think I mentioned smoking, so not smoking, or if you are a smoker, I think instead to reduce it a bit. Alcohol use, certainly any alcohol use is not good for brain or heart or blood vessel health. It's become a bit more controversial because the latest Canadian guidelines are suggesting a lower level of alcohol use than previously was said to be okay. Previous guidance suggested up to 2 drinks a day for a man and 1 drink a day for a woman was okay. And the new guidance is more like less is probably better than more, and to have kind of the minimum amount that we find, socially enjoyable and acceptable. Even 2 drinks a week, more than that may not be great for aspects of health. So that's a bit of a change, right, for a lot of people. And I probably reduced my alcohol use, but I'm not sure quite to where the guidelines are, because I'm here 3 or 4 times a week or something. So that's maybe a healthful amount. So there's a lot of overlap between the risk factors for dementia in general of all causes, vascular dementia. So it's of course I've been saying this for a long time, but it sort of renews my interest in taking care of these things, like all the things that we've heard about to take care of your heart for many years. It turns out these are good things to take care of your brain and body risk of dementia too.
I'm just going to follow up on the alcohol. And I know that there is a lot of uncertainty about this, but if you or someone that you love is starting to develop signs of memory changes without a diagnosis of dementia, or just perhaps even normal changes, would you stop drinking entirely?
Yeah, I think that's not an unreasonable thing to do. Part of what's changed a little bit too is that there was interest from studies done 10 or 20 years ago that a small amount of alcohol intake might be healthy for the heart or healthy for the brain. There may be medicinal kind of effects of alcohol. And thinking around that has changed a little bit with newer evidence. Partly based on evidence from genetic epidemiology studies too, a new way of doing epidemiology. Epidemiology is kind of the study of risk factors essentially. That now that we understand a lot more about genes and how they intersect with health, people can look and say, well, do genes that kind of predispose people to drinking moderate amount of alcohol, is that genetic predisposition linked with lower risk for heart attack, stroke, and dementia? And the answers kind of turn out to be no from these genetic studies. So people wonder whether the old studies maybe were, because it's challenging, right? The people that have a glass of wine or two just are so different than other people in other ways that are hard to account for fully. Because what you eat and what you drink, it says a lot about your background, your wealth, your education level, and other things that might those other factors might be related to why there was an inherent protective effect, and I'm probably less convinced there's a protective effect. So it's become more like, well, on the other hand, it's part of like many cultures around the world and satisfaction with life, and just like with diet as well, you know, what you eat and drink, it's you have to look at the intersection between where you get enjoyment out of life and what's the most healthy part. And you can have to include both of those factors because yeah, lots of things are, you know, it's kind of like, you know, so many different things that you eat affect risk in different ways, right? Like the World Health Organization classified red meat as a carcinogen, for example. So does that mean I never eat red meat anymore? No, I still have a steak now and then, right? We have to acknowledge Alberta is not a very Mediterranean style. We have to red meat, dairy, and root vegetables. That's what grows naturally to eat. So like I said, it's kind of an intersection. I think if for you, like what's most important to you is reducing your risk for dementia as much as possible, probably eliminating alcohol from the diet would be most important with those values. That addresses your question.
Yeah, I mean, it's something I feel like my family talked about a lot this summer while we were in the Mediterranean. Fish, but also drinking red wine. Yes. And so I want to follow up on a point you raised a bit earlier, and this was about Alzheimer's and the biology and being important in the biology is sort of what the diagnosis would be based on if you could do the test to examine the biology. Is that fair?
Yeah, that's if we could, you know, so it's defined as this plaque buildup, but just to be clear, these are microscopic, you know, little aggregates of a protein called beta amyloid. And the protein is derived from, like it's made by your own body, it doesn't come directly from the diet. So we talked about how diet is healthy for the body. You can't eliminate this protein buildup merely by avoiding certain types of foodstuffs alone. But it's microscopic, it's like a few thousandths of a millimeter big, so you can't see it from the outside. It doesn't show up directly on most kinds of brain scans. So the diagnosis of Alzheimer's disease typically is based on the presence of signs and symptoms that are consistent with the disease, plus other tests to rule out other causes. So a doctor should do blood work to make sure it's not a vitamin deficiency or a hormone problem. A brain scan should be done because we can recognize the strokes on a brain scan. By brain scan, I'm referring to CAT scans and MRI scans. But we can't see those plaques, you know, directly on brain scans. Now, there is progress in developing blood tests and what type of tests that would show correlates of the amyloid. Currently in Alberta, the only way to do it would be to have a test called lumbar puncture, or also in lay terms called a spinal tap. So it's a test where a needle is inserted. The spine is made up of these kind of blocks called vertebra, and there's a little space in between them. So you can kind of put a needle in that space and draw some fluid out from around the spinal column. So there's the fluid that circulates around the brain, but also around the spinal cord. And there's a little sac at the end where the fluid is, but where the spinal cord isn't. So there's a place where you can see the fluid out. It's a similar test in some ways to when women get an epidural, for example, or get spinal anesthesia from a knee surgery where they do the rape, but they put their lower body to sleep. It's kind of like that. So instead of putting medicine in, you take some of the fluid out. And that could be sent for tests for the amyloid level. We see as the level gets disturbed because the amyloid's sticking in the brain, we see less of the amyloid fluid. I can diagnose it.
Would that test change management based on the tools we have now?
Yeah, it's because it's a test that requires, like it's a very safe test, but it requires a doctor or a healthcare professional that knows how to do the test. It's not something family doctors do in their office. It is an office test, like it's kind of like seeing the dentist. You go and there's some freezing medicine, there's some the area the test is done. But it requires some work. It's obviously it's a lot more of a reduction than doing a simple blood test, for example. Right? So we don't do that test in everybody. usually we can recognize the Alzheimer's disease well enough based on the signs and symptoms and by excluding the other causes that the test is not needed. There are medications for Alzheimer's disease that are pills that enhance cognition, and so we feel comfortable, prescribing those kind of tests in most cases after doing the work that I described. Currently, we use lumbar puncture tests more in people where it looks like there may be like an alternate cause that we need to understand or rule out, or sometimes where it's a scenario where Alzheimer's disease is less common, like people with young onset dementia. About 7% of cases of dementia are people less than 65. And they're the differential diagnosis, like potential causes, are potentially wider. So we do that test in those kind of circumstances.
And part of why I was thinking about that is I follow a lot of the discussion in the United States about what's happening. And I know that in the summer, there was a blood test approved in the United States. I don't think it's available here, but I know there was media coverage here. And so I just wanted to confirm with you that the status of a blood test that can reliably test for Alzheimer's that is available in Canada, we don't have that.
No, there's currently a blood test for amyloid that's approved by Health Canada. In Canada, there's an American company. It's a certified laboratory that can do testing for blood amyloid. Although the blood test and the technology is still kind of evolving. The accuracy of the blood test is good, but not as good as the spinal fluid test that I just mentioned. The spinal fluid test would be considered gold standard. The other kind of scan, a test that can be done for amyloid is called an amyloid PET scan. So it's a specialized kind of scan where a tracer that sticks to amyloid is ejected in the vein, and then the scan is taken to the brain, and it kind of lights up if the amyloid is in the brain because the tracer sticks to it and labels it. So that's another way of doing amyloid testing, although it's not available like as a routine diagnostic test in Alberta or anywhere else in Canada.
That would be in a rare, unusual situation that someone would want to do that kind of a test.
Yeah, it's another test to document amyloid in the brain, but it's so it's limited availability in the United States. It's a very expensive test too. Amyloid PET scan costs at least around $3,000 per scan, so it's expensive, not widely available. We'll probably talk about medications approved in the United States for amyloid too, because that's where it's come up.
Well, and that's why I was asking these questions. Is there's more discussions about these? They will be integral to what medications may one day be selected for someone. Yes.
So there is a medication approved by the U.S. FDA and covered by U.S. Medicare, which is provides essentially coverage for all Americans 65 and older. That was just approved fairly recently in July, so I think it's just beginning to be used in the United States. Called lecanemab is the main medication. And it's an antibody that binds to the amyloid, and then that kind of signals to the body to strip the amyloid out of the brain. And the antibody is pretty effective at removing the amyloid. What's kind of intriguing and not understood scientifically is, although amyloid is supposed to be a cause of Alzheimer's disease, removing it unfortunately doesn't cure Alzheimer's disease. It does slow the progression of Alzheimer's disease by about 25 to 30%. So the rate of decline is 25 to 30% less in people given this antibody infusion, but it's not 100%, right? So people still get worse after receiving the treatments, but at a slower rate than so it's something we would have been something that just stopped progression, but it turned out not to be the case. Why that is, some more work needs to be done for additional treatments. And there's debate about the value, like how big a deal is it to have, 30% less decline than something without the treatment. But it does modify the course of the disease, and it's the first new FDA-approved Alzheimer's disease medication for almost 20 years. So it is a big difference and a big change. There are some potential risks with this medication. It's also has to be given by an intravenous infusion, depending on the type of medication, once every 2 weeks or once every 4 weeks. So it's not something people can take at home. Like it's not as simple as taking a pill. And it can have side effects of brain swelling or brain bleeding in about a third of people. So people need to be monitored carefully. And it's also an expensive medication. The cost for this medication in the US would be about $26,000 a year. So because of the expense, the health system resources needs to administer the medication because it needs a nurse and have an ID 6 months a month and get the medication. And because it has significant side effects, people only want to use it if we're very certain that amyloid is in the brain. We want to know that it's the kind of person that has the amyloid that could respond to the therapy. So that requires the use of these amyloid PET scans or the lumbar puncture. I don't think people feel that the blood tests are quite accurate enough to determine, to be confident that if you're giving these kind of drugs to people, that they'd be the kind of person that would respond. So from what I understand from my colleagues in the United States, they would either do a lumbar puncture or do the amyloid scan. The blood tests sometimes are used as maybe used as the first stage. You know, like it may be good enough if the blood test is negative, we can say, okay, well, we're not the person that would respond, but if it's positive, it's still our confirmation of this other, more invasive or expensive tests.
And so the obvious follow-up to that is when will we get lecanemab in Canada?
Yeah, what about these medications in Canada? So there is a second medication that's also approved in the United States called aducanumab. The brand name they've given it is Aduhelm. That has a conditional approval in the United States. It was shown to be good at removing the amyloid, but not as clear that the patients were experiencing clinical benefit. That one was, so that has what's called a conditional approval, but the only one with full approval is the medication called lecanemab. My understanding is that the application is made to Health Canada for them to review lecanemab and decide whether to give an approval. My understanding is that the legislation that governs how Health Canada is created and functions gives them a certain time to review the file and make a decision, and that the clock will expire on their timing in spring of 2024, so around March of next year. They could decide soon. They could decide. They may have decided this afternoon. I don't know. Because they could decide tomorrow. I don't know. But then that would be the longest they can take to decide. After their decision, there's a couple of other steps, though. I would say for most medications, if it gets approved by the US FDA, then Health Canada usually approves it. After the approval by Health Canada, if it were to happen, then the drug would be reviewed by an agency called Canada, and they look at a combination of both the effectiveness of the drug as well as the cost of the drug. So they're looking at not just does the drug have any effect, but kind of what's the value for the money, right? What's the effect compared to the investment needed to provide the drug? So they would give input on that, and then Alberta and the other provinces would decide whether they would put the drug on the formulary. And that would require some planning too, because as we talked about, it's not a pill, it's an infusion given intravenously. So Alberta Health Services would need to make sure that they have nurses and people who can have the drug administered. We have to look at the capacity to do these amyloid tests in people and make sure we're fast to do that. So it's some ways away before it could be affordable, before we can have a decision and be prepared to give the drug to people in Canada. I don't know, but as I said, most medications are approved by US FDA, approved by Health Canada. So I wouldn't be surprised if it gets approved by Health Canada. But I think after that, we'll see there will be a conversation you know, as a, you know, as a burden about, because it is expensive too, right? So there's gonna have to be a conversation about the value and how important this drug, you know, having access to this drug will be for others. Because I see a lot of editorials about, you know, is it good enough, right? You know, I don't know, is, you know, having 70 or 75% of a bad thing better than having 100% of a bad thing? I think the answer is maybe. I see a lot of editorials now, they're mostly by doctors. I think there needs to be like the voices of people with experience, like patients and family member, care partners need to be involved in this conversation too, because I think it will take some, I think hearing the voice of patients is going to be impactful in ultimately determining whether drugs like this get on provincial formulary and elsewhere.
How often are the infusions?
For lecanemab, I believe it's every 2 weeks, so correct me if I'm wrong. For the other one, aducanumab was every 4 weeks. And then they were given over a period of 18 months, so there'd be like 18 infusions. There was a third drug called donanemab that is not approved by the US FDA, but also has a positive clinical trial with a similar effect of slowing the rate of decline by about 1 to 1/3. And the US FDA is looking at that. That drug's a bit different in terms of how they studied it, in the sense that rather than just giving it for a period of 18 months, they would check with another PET scan to see if the amyloid had been removed from the brain. And once the infusions have removed all of that amyloid, if that was achieved, which had happened about 30 people, then they wouldn't need any more infusion. They would just kind of give it until the amyloid works out, and then so that was a bit of a different way of doing it. So it may not be that you need to be on medication like this forever, but maybe just until we can show that the amyloid is out. Maybe you only need it again.
And then we'll move on from this, but I know there's so much discussion and so much interest in this. What else is sort of coming in the pipeline? Like if we were to sit here, you know, maybe 5 years from now, what do you see coming towards us that we might be talking about that might be a treatment?
Well, I have to see, you know, so there's another protein that aggregates in the brain called tau. So we think the amyloid is starts the process, but then it leads to this buildup of tangles, which are made of this protein called tau. And this, you know, approach of engineering an antibody, which our body makes normally to recognize foreign things like viruses, and the immune system removes it from the body. So it was a very clever technique to modify these antibodies to recognize things that are building in the body you don't want to get rid of them. So people are working on antibodies that would remove this other protein called tau that causes tangles. The third most common cause of dementia is a condition called Lewy body disease. It's kind of a cousin to Parkinson's disease, and both of them are marked by buildup of a protein called alpha-synuclein. So people are trying to see if you can tag that to remove it. We made great progress in the last 10 to 20 years in recognizing how often people have strokes and other causes of vascular dementia. And finally, some people have more than one cause of dementia. You know, unfortunately, there's no rule that you can only have one thing go wrong. And as you get more experienced in life, which is my life, I'm getting older, sometimes you get multiple systems. So part of what we may find in the future is that to get from 30% less decline to stopping it, we may need to we need to have a kind of a combination treatment attacking different things that are going on in the brain, including maybe things that we don't understand now.
Well, thank you for that detailed answer. I wanted to bring it back to where we are now, and what are the very real things that we know about, and that people can expect. And there is this, people have this journey, and this is true of all of them. There's transition points along the way and things you expect to see. And so can you talk to us about some of those key transition points on this journey, and what, if anything, that people can do to make them less challenging for themselves or for their loved ones?
Yeah, we talked a lot about medications, but there's also kind of, living with the changes, living with illness, and so there's important steps that people can take, right, to help live a full life, despite having something like dementia from various causes. So we talked about the importance of getting a diagnosis and getting help. Part of it, and part of the coping strategies is like having help from care partners, but also, when you move to more moderate, more advanced stages, there are organizations and ways out there to help. So one would be contacting the Alzheimer's Society, for example. There are what are called home care services to help people live in their home for as long as possible with diagnosis of something like Alzheimer's disease, and they can provide help like access to cognitively stimulating day programs or other programs where people can get help with that. To be mentally active, socially active are important things for brain health and for maintaining healthy cognition, regardless of whether you have an illness or not. This big programs that now with that. Ensuring like safety is another part of wellness, and so that means being, all of us need to retire from driving, for example, at some point during life, and for most people, at some point during their journey through dementia, will have to retire from driving at some point. That's important. It's a chemical adjustment to the illness, but it's a practical part of people's COPD. And so these are some of the things that the transition points are. People do often ask me, like, what stage is my illness, right? And there are many different types of scientific tools and research tools and different scales and assessments. I tend to think of it like more pragmatically, I guess. I think of kind of three stages, like there's the mild, the moderate stages, and the later stages. And for me, it's like based on kind of people's functions. People sometimes ask, so do I need to have another brain scan or blood test? We use those mostly for diagnosis, for determining the stage, like what stage you're in. It's more how people are functioning. So I would call them mild stages when people are still living at home and functioning well on a day-to-day basis, and their care partner spouse could probably go away from the weekend and take care of themselves, can make simple meals or heat a meal, can do their own shopping, but still there are demonstrable problems, maybe difficulty with more complex activities of living. I would call transition to moderate stage when some of the basic daily tasks are starting to get a little harder. People need some reminders, like maybe need a little bit of outward rest, reminders for showering. And then I would call it more severe stages when people need more daily help with essential activities of living, including toileting. More severe stages, that's where it's very hard sometimes, even with being in a good environment, right? With a care partner, it's where sometimes people need help by transitioning to a different living environment. It's where they can get more assistance. That's from my standpoint, that's very practical. Three different stages.
I feel I had a lot of conversations about this on the weekend. I have two friends, and in different ways, our families are all going through this, and there was this recurring theme of trying to figure out, maybe a younger generation has a different view of what is safe than an older generation, and how to manage those conversations. And I know that Alzheimer's Society is so good at this, but I wondered, with all your experience, do you have any suggestions to help caregivers, kids, have those conversations with their parents about what is safe? Acknowledging that I think sometimes we're also a little overprotective.
Yeah, I think exactly, you know, life includes risks, like living with your life. And so it's a balance, right? And so, I think sometimes the challenging scenarios are, um, when the person affected by dementia, you know, sometimes it comes with some difficulty with awareness of some of these risks, what we call in medical terms like the insight, right? It's not the person's fault, but you know, it's the illness that has affected the insight. Sometimes it can make it hard to recognize risks and accept help. Um, but we have to kind of be clear, but also be respectful of that person's person. And another challenge sometimes is that care partners, spouses or children, understandably, you know, it's their loved one, right? And they want to protect them from all risks.
Yeah.
But we have to also give people the road for their own autonomy and to live their own full life, and that includes accepting some risks. So it's finding the intersection between those two things can be difficult, and both sides need to be willing to compromise and negotiate. You know, one aspect that can be more helpful, can be increasingly helpful, that maybe wasn't there so much 10 or 20 years ago, are like technology as well, right? Like if the concern is over going out for a walk and getting lost, well, you know, having my phone here, you know, my wife can check in on me so she knows I'm helping out somewhere then in case she's wondering where I'm at, you know. So you can use technology sometimes to help. You know, again, with the technology, sometimes there's also a balance between autonomy and independence and safety and monitoring. You have to find the right balance, but I think it does offer some abilities to feel like people can be safe, but also preserve as much as their autonomy as they want. So,
On the technology front, and my parents are here, so I can tell the story. I was walking with my mom in Cyprus this summer, and she tripped, and she was okay, but I moved so quickly to help that I had an alarm go off on my Apple Watch that said, "It appears you've fallen. Are you okay?" On my and so now we're getting my parents Apple Watches, because well, one, they love it, and so it's a good fit, but it just, I had no idea, like it was so sensitive to how quickly I moved. It just seemed like a wonderful thing. It's for the data is what we're giving them to them, but it makes me feel better.
yeah, no, I think, and my parents have them too, actually. So, and it's happened when I've gone to big costs, they probably know how to trip.
Yeah.
But they're, you know, they're meant to be a little bit sensitive, like overly sensitive, so they do generate some false alarms. But I've seen it in action, like, so the technology works pretty well, actually.
How are we? Well, I guess it's time for question and answers. So
Before we move into question and answers, I just wanted to thank the two of you. So well done. Thank you so much. I found our mics. And also I wanted to mention, you know, when you talk about the brain healthy diet, I remember you mentioned chicken. A number of my team members went for supper before tonight, and one of them had some chicken fingers. Would that fall into maybe the harm reduction?
Pride would be occasion.
Okay, we'll make note of that to my team. So we're going to move into the question and answer period. We have about half an hour. We're going to get to as many as possible, but a couple of reminders, please keep the questions general. If you have a specific question or something that feels a bit personal, please reach out to our office, or we also have some dementia support navigators circling around. They're all wearing these name tags. There's a couple in the back. Sorry to put you on the spot. Sorry. Feel free to ask them questions as well at the end of the program. And I have lovely Megan, our communication specialist, who's also responsible for this great slideshow helping me out tonight. So if you do have a question, raise your hand and we will do our best to get them in order. Megan, I think we've got, we got a competition. Okay, I'm gonna do my best. I think there were 3 up there first. We'll go to the gentleman in the suit first. Okay.
All right, I'm headed over there.
Okay, I'll head over here.
Can everybody hear from this mic?
Yeah.
Okay, good. Close, like an ice cream cone. Okay.
Thank you. Can you hear me? Hi, my name is Sean. So my grandmother recently had a stroke about 3 months ago, and she's been living with vascular dementia. She's in a long-term care facility. And my family's trying to recognize how much time we should spend with her. And my question is, how much do people with vascular dementia recognize the passing of time? And is spending a full 24 hours the same as spending 5 hours? And is there a difference? And just want to make sure that we're respectful of my family's opinions and making sure she's taken care of properly and not overindulging, if that makes sense.
Yeah, no, that makes sense. I hear similar tensions with other families, and then there's a few dimensions to this aspect. So, and I'll speak in generalities here, of course. Their specific circumstance. But I think one thing we recognize that social interaction is very important, right, for brain health. From that standpoint, it's good to have interactions between family members and others. But just like about anything that's kind of good for your body, there can be too much of a good thing too, right? So people, and it also depends on people's own interests and personality. Some people are more introverted, right? And they need a little bit of time to themselves for reflection, and that's kind of enjoyable for their mental health. Other people are extroverts and they really get energized by having other people around. So it has to be individualized for each person, like mental health and brain health benefits they get from interaction. And sometimes, particularly early on in the course of an illness, we do have to remind family members sometimes that it's okay to give them some time on their own, right? To avoid, there is such a thing probably as overstimulation, right? So that's one aspect. The other aspect is there's also, we have to think about the health of the care partner, right? And the family, because we know being a care partner comes with its own stresses, right? And lots of health outcomes we see are worse in care partners, driven by the stress. So particularly early on, like with a sudden event like a stroke, where there are some changing health, family members' instincts are often, I gotta be there like all the time, like all day, every day. And we have to remind sometimes the family that for your own health, and because this is not a short-term thing, but it's going to be a long-term thing, we don't want you to burn yourself out and stress yourself out and the family out too, because taking care of your own health is family members' health is important as well.
Thank you so much. Hey, Rachel.
And in Alzheimer's Calgary, we really talk about dementia as being a marathon, not a sprint. So keeping that in mind about, it's so important for the care partner to take good care of themselves and to ensure that they're getting their own needs met so that they're able, the old saying, you can't pour from an empty cup, ensuring that your cup stays as full as possible as well. Megan, you were directing me to somebody over here, I think you saw.
I did see a hand up over on your side of the room. Then over here.
Hi there, my name's Ashley. I wrote my question out. Could you tell me what role trauma has on the risk of developing dementia, if any?
Yeah, it has a role. There's both physical trauma, like to the head in the form of a traumatic brain injury from, like a motor vehicle accident or there's been a blow. And then there's also a role for kind of the mental or psychological trauma as well. So there's kind of 2 types of trauma I think about. Both are risk factors for dementia. We don't fully understand all the reasons why. If there's been a physical blow to the head, sometimes there can be actual damage to the brain, like a bruise on the brain, or other forms of brain injury, like a scar left open. And that can decrease what we call the cognitive reserve or brain reserve. You know, all of our, as we get older, we accumulate some wear and tear on the brain, just like we do on our joints. And a brain that's been healthy up to that point can kind of take more of the wear and tear without showing symptoms. But if the ability to tolerate that wear and tear has been reduced because of a scar on the brain from prior head injury, then they make someone more likely to experience the symptoms of dementia later, like for example, if there's some Alzheimer's changes in the brain. And this is all backed up by studies too, showing that as a risk factor. Psychological trauma too, like we see from people who've had a life-threatening event or experienced abuse, like this is understood also to be a risk factor. Again, we're not sure why. Maybe it does something to just make the brain more vulnerable to developing problems in later life because the capacity of the brain to be resilient in face of injuries has been reduced. But that's definitely a factor as well. So these are factors.
Okay, I have a question over here, or do you want to take yours first, Mike? Okay,
I'm sitting right here. I can sit from there.
okay.
Can I?
Yes, please go ahead.
My name's Terry, can you hear me?
I can.
Yeah. The question is similar to what the lady just asked now. My question is anxiety, relationship to dementia, and then leading on to full-blown Alzheimer's dementia. Can you explain that to me? I've been in a situation where that's happened to me over the past 5 years. Not me personally, but my wife.
Sure. Again, I want to be humble. I can explain what I know from my experience as a physician and talking to patients and being researcher, understanding scientific literature, but there's still lots of questions about all of these things, right? And we're often better at tagging and saying, oh, this is a risk factor than necessarily understanding why and how to change it, right? So that I have to acknowledge that's not the case. So anxiety is both a risk factor, but also a consequence. So, and there's differences depending on whether it's a lifelong problem with anxiety or if it's something that's emerged in later life, like in the 50s, 60s, or 70s. Some people just have a brain that's kind of wired to a tendency toward anxiety. There's a mental health condition called generalized anxiety disorder about people that worry about things, the worry wards, right? And this is but it's to an extent where it interferes with their independent functioning, and this is often manifests in kind of adulthood, and then it persists throughout life, and that, just like we talked about with the psychological trauma, that I think has a wear and tear effect on the brain. Scientifically, we don't exactly know how to measure this part, but that's a risk factor for later life. Dementia. We also see that anxiety is a consequence of dementia. So dementia is defined as a medical terms a lot around kind of memory and concentration, but of course the brain is what makes us feel as well as what makes us think. And problems with feeling and behavior often come along with these memory problems. In fact, when you take careful history from patients, you often find that it may be anxiety is the very first symptom, and then it was only later that people became it, but it was part of the same process. So I think if someone who's never been anxious before in their life, but now in later life is starting to become anxious about everything, to me that's a worrisome sign. And just like we talked about, what are the kind of signs in terms of forgetting things that might lead you to talk to a doctor? I would say the same things if about being anxious or being depressed. Other things we see sometimes is people kind of their mental energy goes away, they just can't do things anymore. The medical term for that is apathy. Or we see that people are sometimes become impulsive or like overly friendly, talking to strangers, or if they weren't normally doing that, or making jokes that are kind of inappropriate. You're like, and it's different than their personality. These things can be signs that there's a change in feeling too that can be brought to doctor's attention.
I'm just inquiring if there's research or studies being done in Calgary at Foothills Medical Center and UC. Sorry, I'm asking if there's studies or research being done right here in Calgary at the Foothills Medical Center and the UC medical community. And if so, what is the studies and where we are with them?
Yeah, there's probably, so there are a number of studies going on locally at the university of various types. Probably the best way, there's too many to summarize quickly, although maybe I'll summarize one because everybody in the room is eligible to participate. And I'm actually a subject in the study too, so I'll come to that one. But probably the best way to learn about them would to go to the University of Calgary website, where they have a where you go there, you can like search for research studies, and they have a list of different ones, not just for brain health, but also studies, for about the kidneys, about heart attacks and all this kind of thing. So you can go to the university website to find more information. The one I'm thinking of that maybe everybody could contribute to, if you're willing to spend a couple of hours and you have access to the internet, is called Can Protect. And that one is, so if you Google Can Protect, which is can-protect.ca. And that's run by a colleague of mine at the University of Calgary, Dr. Ismail. And it's a web-based study where you would do a bunch of questionnaires about your health, about experiences of having head injuries or having a history of psychological difficulties or traumas in your life. It will even have you do some kind of brain games, so like memory tests online. The study is for anybody who's 50 and older, so that includes me. And it's also for anybody who's providing care as a care partner, either informal, as we'll discuss, or a paid caregiver, like you work in a long-term care facility, to understand their experiences with caregiving as well. So that's canprotect.ca, and it's there's a lot of questionnaires, so you have to be patient to go through them, and the memory tests, of course, range from easy ones to harder ones, so they're not easy. But it's a way that pretty much, like many of us in the room could contribute to research on understanding risk factors and causes might be part of that study. So that's one that I'll highlight because it's very broad study.
Thank you. I have a question right here.
Hi, thank you for being here with us this evening. My wife and I are dealing with dementia on two fronts. Her dad has it, my mother has it. My question is, when they make strange statements or statements that are false or incorrect, what does a person do? Do they correct them? Do they not correct them? Do they just go along with it? We're very confused with this.
Yeah, I'd say generally, it depends on the circumstance of the person. Generally, it's probably best to go along with, right? The exception, of course, if it's around or is spurring a behavior and activity that would not be safe for that person. Sometimes then redirection is the another strategy can sometimes be just to take a break, from it and from this situation a little bit too, and perhaps let people move on to a different topic. Right? It's not this false information, false topic. The reason I say that is because there's some level of frustration. It's not easy being corrected, saying, "Oh no, you forgot it's this and that." I'm like, nobody likes to do that. So I think constant redirection and correction, particularly because there's forgetfulness, it's hard to learn to correct the behavior in the first place. Then it's just frustrating for the person. It's also frustrating for the care partner, we have to acknowledge too, to hear the same question over and over again too, so that's a little bit hard. Two other things you can think about. So that's partly why getting some respite now and then is helpful too for everybody. It means kind of taking a break, right? having a neighbor come over, maybe to spend some time, break between the care part of the person. I think talking to the Alzheimer's Society, they can point you to possible, day programs or other things where it's, good for each person to get a break, get their own thing. There's a website that I point my patients to frequently called igericare.ca. It's IGERICARE.ca. And it's run by Hamilton Health Sciences, so it's a Canadian medical center, and it's got good information about some of the symptoms that go along with dementia and what they're about, and also some like tips or strategies for how to go through. I think the Alzheimer's Society here too, they also run classes and programs to like focus on some of these aspects, like how do you live with the condition, both as someone affected by it, but also as a family member or a friend. So I think the Alzheimer's Society got it.
I have a question right here, and then I've got two more, and then we will unfortunately be closed for questions. Please don't be mad, I'm so sorry. If we weren't able to take your question, please connect with us, either tonight or give us a call at the Alzheimer's Society. So after Megan, I've got the gentleman in the red shirt, and we've looked at each other a few times, so.
My name is Jim. Dr. Smith, you're a vascular specialist in this field. My wife has been diagnosed with vascular dementia after a heart attack. I find there are very little information from the Alzheimer's Society, from the cardiologist or family doctor, as to who we should really approach to assist us in helping people with vascular dementia. I'm wondering if you can provide us with some assistance as to where I and other people who have vascular dementia.
Yeah, I guess I can think of maybe three pieces of that. One aspect is just I acknowledge what you're saying, right? Like when you read or hear about dementia, a lot of it is focused on Alzheimer's disease, understandably because it's the most common cause. But sometimes other causes like vascular dementia, you find it's like hard for people to get information. So I just acknowledge that's one of the challenges, right? And we need more information for people. Don't overlook though that the Alzheimer's Society is here to help people with all different kinds of memory problems, not only Alzheimer's disease, although it's in the title of the society. I know from my patient's experience and what they've emphasized to me as well, and they live by it. They're there to help people with all different kinds of memory problems, not just from Alzheimer's disease. So don't overlook that the Alzheimer's Society is a resource. And of course, many of the symptoms and coping with the changes day to day are very similar between different types of dementia, because they're all defined based on the problems with memory and thinking. So don't overlook that aspect. Finally, of course, with vascular dementia, we know that there are a lot of ways that we can address some of the risk factors. So don't overlook also like to talk to your family doctor, or if she's a cardiologist or others about management of these risk factors too. It's important to monitor the blood pressure and make sure it's well treated, to take the medications for reducing risk of heart attack if any of them are prescribed and so forth. So that's an important component too. So let's say those are three things that we can do to make a difference. Thanks.
Thanks so much, Dr. Smith. And yeah, just acknowledging too, sometimes people can feel frustration just because at Alzheimer's Calgary, we really focus on the social parts of the disease. So how can we help you live as well as possible for as long as possible and have as many meaningful moments as possible, when we don't focus on the medical pieces because we're not medical experts. And that's sometimes a gap for people to struggle with. And that's, it's that piece where we can't do everything for everyone, but we really do our best to help people navigate those social parts of the disease as well. All right, gentlemen, sure.
Hi, doctor. I would be very interested in your comments as to what's the sleep play in all this.
I'll repeat the question because like me, you're not an accomplished celebrity. In other words, our mic skills are not great. But so the question is how does sleep? Sorry. Oh, sorry. So the question was about sleep. What's the relationship between sleep? Yeah, sleep is it's like anxiety. It's another complex phenomenon that's both a risk factor for dementia as well as disturbances in sleep are a consequence of many of the conditions that lead to dementia. So what's known is that thinking of sleep as a risk factor, both too little sleep and too much sleep have been linked in epidemiological studies with risk for dementia, as has fragmented sleep, like kind of the more episodes of waking up and tossing and turning and not having, kind of moving, having the deeper levels of sleep like interrupted. There's also a specific sleep disturbance called REM sleep behavior disorder, where people act out their dreams while they're sleeping. Like, in other words, they're physically doing what they're doing in the dream. Normally there's kind of a switch so that if I'm running away from a monster, I'm not actually, moving arms and legs in bed, but in some people that switch doesn't work right when they're sleeping. And they actually kind of act out the dreams. And that could be a sign of a specific kind of dementia called Lewy body disease. So getting good sleep. Now, what's not clear is whether improving sleep reduces the risk, although we generally recommend, try that getting good sleep, like for most people, physiologically they need like 6 to 8 hours of sleep, a little bit less maybe as you get older and more when you're a teenager, but like 6 to 8 hours of sleep. That's not always easy, right? I hear lots about sleep in the clinic because it's something that's a lot of people have insomnia, and there's not necessarily an easy fix. And some of the medications to improve sleep have sedating effects that we think are not great for the brain. So ideally you can fix sleep without medications, but I acknowledge it's like a challenging part. And when people have illnesses like Alzheimer's, then it often turns around and affects sleep, right? And we see two main things that I know about and hear about. One is that the total amount of time spent sleeping tends to go up as people's illness gets worse. So some people sleep a lot, with conditions like Alzheimer's. 10, 12, even 14 hours a day, I hear from some of my patients. But then the other problem is that circadian rhythms get mixed up. So their brain is confused about what time of day it is. So people may sleep too much, but they're sleeping in the wrong parts of the day. Sleeping during the day and up at night, for instance, or kind of waking up at 3 a.m. and getting ready to go to church or something because their brain is mistakenly telling them that it's morning time and time to get up, even though it's the middle of the night. And of course, that's challenging for the other people who live with them because, that's also a challenging condition to cope with, because medications that we try sometimes like melatonin, they only have kind of modest effect. A lot of it is just trying to kind of keep the orienting signals clear, right? Like being exposed to sunlight during the day helps keep people up, and then so at night when it's darker, it helps kind of make the circadian clock work as best as possible, but it can be a challenging part. So that's sleep, so that we don't fully understand the relationships of why it's a risk factor. It's both a risk factor and then it gets disturbed as part of these conditions.
We have the last. I don't have lots of mics. We have the last question of the night. I can roll it out for you if you want. I can pass that one. Oh, good. We got one more mic that has some light in it.
Yes. Thanks, Dr. Smith, for all your information. I have kind of a legal question. I have a friend in British Columbia, Burnaby, who was diagnosed with Alzheimer's about 3 or 4 years ago, joined the Alzheimer's organization,
For some reason or other, in the last couple of years, she has completely separated herself from the organization, plus all of her friends. She tells me that I'm the only one that she trusts. I've been encouraging her to get back to the Alzheimer's. She says, no, I don't trust them because they're gonna put me in a home. And as such, I'm probably gonna die where I am. So I'm in a dilemma here. I'm trying to get information from DC as to how I can go through the back door. I don't want to deceive her by doing this, but she needs help. And right now, I'm the only one that is available because she rejects everybody else.
Yeah, this is a very challenging type of scenario, and you're not the only one to experience this, of course, right? And of course, I can't give legal advice because I'm a doctor, not a lawyer, but I hear very similar stories. I know more about the Alberta situation for some of these rules vary by province, but I think what we try to encourage everybody to do, with or without it, as any kind actually, is to make some plans in advance, right, about who that person wants to be authorized to provide legal help, including making decisions about how their money should be spent, right, if in the future circumstance are unable to spend it, or with whom they would live with and associate with. So that's the former, the kind of financial issues are done by designating power of attorney. Latter, at least in Alberta context, are addressed by creating a personal directive that would designate which person could direct, decisions about with whom one would associate or to live with. Someone should do that in advance, and everybody should do it. So I've done that. It's important for your autonomy to designate who this person will be, because if you become disabled and unable to make your own decisions without having designated such a person, you would have to go through a legal process called a guardianship, where the courts would essentially designate who your guardian should be. And if there is no next of kin, they may have to appoint someone hired by the court or a court officer to do it. For most people, they would prefer for themselves, right, to designate who they trust to take care of themselves rather than the court, decide for them. But you do need to see a lawyer or be able to draft the appropriate legal document, like to designate who this person will be, so that's all going to be really on the up and up and binding. Most times people would say, like, maybe do your will at the same time as well, so you can set goes along with one things. Someone can, pass their legal powers on to their power of attorney voluntarily, but it could also do so if they lack the capacity at some point in the future to make their own decisions. And that's in Alberta, depends how the legal document is going on. In Alberta, that generally requires an opinion from the designated person in the power of attorney, plus some sort of health specialist, which is usually a physician or psychologist, or sometimes two physicians or psychologists to designate that person's capacity to make decisions. We're a society that prizes independence and autonomy a lot. Thinking about our values and wishes in the Canadian society. So people have a lot of leeway to make decisions for themselves, for good or for bad. The only way legally to go against those wishes is with this power of attorney, or if they were to be actively suicidal or homicidal or unable to take care of their own daily needs. Those would be the only way that the police could interrupt to bring someone to hospital for attention. There's a big area before that, though, where people are taking care of themselves on a daily basis, although maybe you're worried that they won't be able to in the future. But they're making decisions that maybe most people around them would say, well, these are not great decisions for them. And then we have to try to, find ways to have people feel safe and comfortable and help them make the best decisions possible. But it is a challenging type of situation to be in.
And if folks have questions about enduring power of attorney or those financial documents, please contact us and we can get you more information about that as well. and we do not have power. So if anyone is worried, we have no power. Thank you so much, Christina and Dr. Smith. It has been an absolute pleasure to have you. And thank you everyone for coming and taking time out of your schedules to be here tonight. We really appreciate you and we hope you have a wonderful evening. Take care. And if you filled out an evaluation, you can just drop it off at the registration table. Thank you so much.